Exactly how we communicate with that.
Well, the only reason why is because of the discussion around the weekend.
Yes, sir.
So,
Good afternoon, everyone. Would like to get this meeting started with the Health and Human Services Subcommittee. Colleagues, at this time, we only have one agency readout. That's the Department of Human Services. And we have Ms. Bugel joining us today. Ms. Bugel.
Thank you, Mr. Chair. The budget for Social Services Administration increases by $25.4 million or 3.1% to a total of $841.8 million in fiscal 27. We will start with the MFR data. Exhibit 1 on page 6 shows child safety performance measures. Percentage of children experiencing no recurrence of maltreatment decreased by 1 percentage point in fiscal 25. The rate of victimization decreased by 41.3%. Exhibit 2 on page 7 shows rate of placement moves. The rate of 6.2 in fiscal 25 represents a move every 161 days. Exhibit 3 on page 8 shows 24.3% of children in out-of-home care exited to permanency within 12 months of entry into care in fiscal 25. Exhibit 4 on page 9 shows that the number of reports of adult abuse or neglect increased by 4.8% in fiscal 25. Language in the fiscal 26 budget restricted funds pending submission of MFR data. DHS has submitted the required data and DLS determined that the information provided complies the language restricting funds. DLS recommends release of $100,000 in general funds and will process a letter to this effect if no objections are raised during the hearings. On page 10, we have the proposed deficiency. The budget includes deficiency totaling $30.2 million, majority of which is associated with foster care shortfalls. Exhibit 5 on page 11 shows the overview of agency spending. Foster care maintenance payments account for $435.6 million. Personnel expenses total $309.2 million, most of which support personnel in local child welfare service programs. Exhibit 6 on page 12 is the proposed budget change chart. Fiscal 27 allowance increases by $25.4 million, primarily due to an increase of $11.2 million in employee and retiree health insurance. There is a $7.7 million increase in foster care maintenance payments, reflecting estimated caseload increases. Exhibit 7 on page 14 shows annual average foster care caseload data. The fiscal 25, the number of youths in out-of-home placements increased by 7.5%. Among individual placement types, regular foster care increased by 24.9% and purchased institution increased by 2.6%. DHS reports that the increase in regular foster care is primarily associated with policy and administrative changes that prioritized placements with kinship caregivers. Fiscal 26 data through December 2025 shows that the number of youths in out-of-home placements has continued to increase. Exhibit 8 on page 15 shows average monthly number of subsidized adoptions and guardianships. Subsidized adoptions decreased in fiscal 25 and 26, while subsidized guardianships has increased in fiscal 25 and continues to increase in fiscal 26. Exhibit 9 on page 16 presents caseload projections. DLS estimates that overall placements will increase by 2.9% in fiscal 26 and will continue to increase in fiscal 27. Exhibit 10 on page 17 shows average placement costs for select placement types. Average costs were highest among purchased institutions, which increased by 36.4% in fiscal 25 and has increased by an additional 10.4% in the first half of fiscal 26. This increase is due to the new foster care rates that apply to institutional providers in fiscal 25. DHS provided a report with information on expenses associated with implementation of the first phase of rate reform. As shown in Exhibit 11 on page 18, the total expenditures for purchased institutions in the report was $38.3 million more than the total expenditures reported during the closeout. We are asking DHS to discuss why the expenditures in the report did not align with the information provided during closeout. On page 19, there is a discussion on the Medicaid state plan amendment. Federal Medicaid reimbursement is available for certain costs under the revised foster care provider rate system, and being able to claim Medicaid funds was a key reason for initiation of rate reform. DHS had previously reported that the Department of Health would submit a state plan amendment with an effective date of July 1st, 2025. However, as of this writing, the SPA had not been submitted. We are asking DHS to comment on when the SPA is expected to be submitted and when Medicaid claims are anticipated to begin. DLS recommends adding a section that restricts funds in MDH and DHS pending submission of a report confirming submission of the SPA. Exhibit 12 on page 20 shows expenditure forecast for foster care maintenance payments. DLS forecasts a shortfall of $18.6 million in fiscal 26. In fiscal 27, DLS projects a shortfall of about $17.4 million. Exhibit 13 on page 21 compares average caseload and payment assumed in the allowance with DLS estimates. DLS estimates higher regular foster care cases and purchased institution placements, as well as higher payments for purchased institutions. The year-to-date experience led to higher caseload growth rates in the DLS estimate. DLS also assumes expenditures associated with flexible funds in fiscal 27 will be less than the allowance. The expense for children placed in hotels is accounted under flexible funds. Following DHS's directive to end hotel stays, DLS assumes costs associated with hotel stays will decrease, reducing flexible fund spending. Committee narrative in 2025 JCR requested DHS to provide costs associated with hotel stays with submission of the fiscal 27 allowance. DHS did not provide the requested data. DLS recommends adding language restricting funds pending submission of data on costs associated with hotel stays. On page 22, we have the personnel data. As of December 31st, 2025, SSA had 172.8 vacant positions. In October 2025, the Board of Public Works approved abolition of positions statewide. 30.5 positions were abolished from SSA. Overall, the number of positions in SSA decreased by 42.53, reflecting internal transfers within DHS. Moving on to the issues starting on page 23. The first issue discusses hospital overstays for children and youth in out-of-home care. As shown in Exhibit 14 on page 24, between October 2023 and September 2025, there were 512 emergency room admissions. Exhibit 15 on page 25 shows data on hospitalizations. Between October 24 and September 25, there were 717 admissions to medical hospitals and 511 admissions to psychiatric hospitals. Compared to the same period in previous year, admissions to medical hospitals increased by 639.2% and admission to psychiatric hospitals increased by 136.6%. DHS indicated improved reporting contributed to this increase, although it is unclear how much of the increase relates to reporting improvements. Exhibit 16 on page 26 shows the average length of overstay for youth placed in medical and psychiatric hospitals. Average monthly overstays ranged between 2 to 78 days for medical hospitalizations and between 11 to 107 days for psychiatric hospitalizations. The second issue, starting on page 28, covers children and youth in out-of-home care placed in hotels. Between October 2024 and September 2025, 93 children experienced hotel stays. Exhibit 18 displays the number of children in foster care placed in hotels by jurisdiction. 15 jurisdictions had at least one child that was placed in a hotel during this period. The overall average length of stay in hotels was 38 days. Exhibit 19 on page 29 provides information on children who experienced hotel stays categorized by age. Children between ages 14 and 17 represented 59% of total children, followed by youths between the ages 18 and 20 at 21%. DHS notes that when children under the age of 11 were placed in a hotel, it was primarily done to keep siblings together. In January, the Office of Program Evaluation and Government Accountability released a report with a scoping evaluation of SSA. The evaluation found that children stayed in hotels for various reasons, including lack of appropriate placement options, guardians' health reasons, and youth's refusal to enter certain placement types. OPEGA notes that some of these reasons were likely beyond the ability of DHS to prevent. In September 2025, the Office of Legislative Audits released a fiscal compliance audit for SSA. One of the audit findings found that 280 foster care children were placed in a hotel under the supervision of a one-on-one vendor between fiscal 23 and 24. The audit also reported expenditures associated with these children totaled approximately $10.4 million, consisting of $0.9 million for hotel costs and $9.5 million for one-on-one services. The audit also found that SSA did not have a procedure established to ensure that individuals with disqualifying criminal backgrounds did not interact with children under its care. This includes lack of criminal background checks for vendors providing one-on-one services to children placed in hotel. Following the death of a youth in DHS's care who was placed in a hotel, DHS directed the local departments to stop facilitating stays in unlicensed settings. The directive also required the local departments to move all youth in hotel stay to an appropriate placement. Exhibit 20 on page 31 shows stays in other unlicensed settings. Between October 24 and September 25, there were 54 such stays. Issue 3 covers child fatalities involving child abuse and neglect. As shown in Exhibit 21 on page 32, through June of calendar 25, there were 21 child fatalities involving child abuse or neglect. Exhibit 22 on page 33 shows a breakdown of child fatalities by age. 44% of the total fatalities involving abuse or neglect involved infants. DLS recommends adopting committee narrative requesting DHS provide data on child fatalities. On page 33, there is a discussion on the State Child Fatality Review Team. Language in fiscal 26 budget restricted funds in DHS and MDH pending submission of a report that indicated the review team had met. The report was submitted in January. DLS determined the information provided complies with the language restricting funds. DLS recommends the release of $250,000 in withheld general funds in both DHS and MDH. DLS will process a letter if no objections are raised in the hearings. Issue 4, starting on page 34, covers the fiscal compliance audit published by OLA. The audit identified 14 findings, of which 6 were repeat findings. OLA noted that certain findings has been repeated since 2008. SSA's overall compliance remained unsatisfactory for the third consecutive audit. Among others, the audit found that SSA lacked effective oversight to ensure local departments properly administered the programs. The audit notes that SSA did not ensure children received required medical and dental care. SSA did not recover overpayments for foster care and also did not meet federal foster care performance requirements. And SSA also did not complete the Title 4E eligibility determinations, resulting in potential loss of $22.5 million in federal reimbursements. Issue 5 covers the out-of-home placement across all state agencies. Exhibit 23 on page 36 shows the number of children in out-of-home placements across all agencies has declined in recent years. As shown in Exhibit 25 on page 39, 324 children and youth experienced out-of-state placement during fiscal 25. Of the total, 91% of the out-of-state placement were associated with children under the care of DHS. DHS has previously published monthly out-of-home placement data on its website for children in its care. The most recently posted data available is through December 2023. Although DHS has been submitting monthly data in fiscal 26, the submitted data does not include all the information that were usually uploaded on the website. DLS recommends adding language restricting funds in fiscal 27 pending submission of a letter confirming the monthly data have been published. Exhibit 26 on page 40 shows that in fiscal 25, the rate of removal into out-of-home care was 1.1 per 1,000 children under age 18. Decline in rates of removal is reflective of DHS's focus in recent year to reduce the number of children entering foster care by preventing unnecessary out-of-home placements through the provision of alternative in-home services. Exhibit 27 on page 41 presents rates of re-entry into out-of-home care for children within 12 months of exiting care to reunify with the family of origin or exiting to guardianship. In fiscal 25, the rate of re-entry from exits to reunification increased by 3.6 percentage points. DHS should comment on the reasons for this increase and its efforts to reduce the rate of re-entry. Exhibit 28 on page 42 covers in-home family preservation cases. In fiscal 2025, the number of cases decreased by 21.8%. DHS should discuss the decrease in in-home family preservation services. Starting on page 45 is the recommended actions. The first recommendation is an annual language restricting general funds appropriated for child welfare services program to that use. Second recommendation is an annual language restricting general fund appropriated for foster care maintenance payments to that use. Recommendation 3 restricts funds pending submission of a report on caseload data and field positions assigned by jurisdiction for specified caseload types. Recommendation 4 restricts funds pending submission of a report on stays in hospital, hotels, and other unlicensed settings. Recommendation 5 restricts funds pending submission of a report on status of corrective actions related to the fiscal compliance audit. Recommendation 6 restricts funds pending submission of a letter confirming the posting of monthly child welfare data. Recommendation 7 restricts funds in DHS and MDH pending submission of a letter confirming submission of Medicaid SPA. Recommendation 8 restricts funds pending submission of 2 reports providing costs associated with children and youth in out-of-home placements placed in hotels. Recommendation 9 is a committee narrative requesting an update on the implementation of provisions of Family First Prevention Services Act. Recommendation 10 is a committee narrative requesting a report on child fatalities. Recommendation 11 restricts general fund appropriated for foster care maintenance payments provided through deficiency appropriation to that use. There are 3 updates starting on page 54. The first update covers the child welfare caseload and staffing report. Update 2 covers evidence-based practices. And the third update discusses the draft rate for second phase of rate reform that was originally scheduled to be implemented in fiscal 26 and is now planned for a future year. That concludes my presentation, and I'll answer any questions you may have.
Thank you, Ms. Bujel. Seeing no questions at this time, we'd like to bring up the agency.
Good afternoon. Chair McCray and committee members, my name is Gloria Brown-Burnett. I am the Deputy Secretary for Operations and soon to be the Acting Secretary until April 1st, which I will be counting down. I would like to first thank the Governor and the Department of Budget and Management, as well as Suveksha, our DLS analyst, for her assistance and analysis of the SSA budget. I want to acknowledge the leadership team here with me today. I'm going to start first with Jeremy Baker, the Governor's Legislative Officer, who has joined us at the table. Dr. Alger Studstill is to my right, Executive Director of the Social Services Administration, or SSA, as you all refer to it. Chief Financial Officer Roman Napoli, and Chief of Staff Webster Yee. And in the audience, Baltimore City Director of Social Services, Brandy Stocksville. Okay, she's en route. And then key senior leaders from the Social Services Administration are present with us here today. I want to say that the safety and well-being of Maryland's children are our highest priorities. We envision a Maryland where all children are safe from abuse and neglect, thriving in permanent homes surrounded by loving families. When we began the hard work of realizing our vision 3 years ago, we knew we had to rebuild trust and modernize a system that had fallen behind. We are modernizing by strategically focusing on our Family Matters approach in 2 key areas: stabilizing and preserving families by providing family-centered, child-focused, community-based services so children do not unnecessarily enter foster care. If children must enter foster care for their safety, we prioritize placing them with kin, whether by blood or by choice. We implement our strategic reforms by making systemic changes that address the root causes of long-standing child welfare problems and resolve our repeat audit findings. We are investing in people, standardizing practice and accountability, and implementing policies that close loopholes and protect children. Together, these systemic changes address the root causes of long-standing long-standing child welfare problems and resolve our repeat audit findings. In federal fiscal year 2025, we responded to 17,919 Child Protective Services cases and supported families of 10,654 children with family preservation services. As of February 18, 2026, there are 3,778 youth in DHS out-of-home care in Maryland. There are no youth in hotel stays. There are 6 youth in DHS care and custody experiencing a hospital overstay, a 65% reduction from January 2025 when 20 youth experienced hospital overstay. When we came into office, there was no way to centrally track the number of children in hotels or hospital overstays across the state. That has changed. We are determined to ensure that all placement decisions align with permanency planning principles and that youth are placed in the least restrictive, most family-like setting that meets their needs. We appoint, I'm going to speak to the investment we're making in our people. We appointed a new SSA director in 2024, although it feels like he's been here forever, and rebuilt the SSA leadership team to centralize oversight and promote consistent practices across the state. We filled chronically vacant caseworker positions, dramatically lowering the vacancy rate from over 17% in November 2022 to just over 6% in February 2026. And we are retaining staff. Our overall average team experience increased by nearly 2 years from 9.54 years in November 2022 to 11.53 years today. And I'm gonna stray. Just having been the previous director in Prince George's County, that is a significant impact in practice and policy, because keeping seasoned social workers means that we improve the delivery of services. So to speak more about our practice and policy changes, I will now turn it over to Dr. Studstill, Executive Director of the Social Services Administration.
Good afternoon, Chair McCray and members of the committee. Upon my arrival in this role, we took immediate corrective action to improve system, program, and service delivery. Thus far, we conduct 100% background checks for all care providers when legislative auditors flag the issues. We've built in new fiscal controls last summer to ensure management review for expenditures and instituted practices to maximize federal reimbursement across the entire department. As a department, we're also developing tools to more closely track procurement activities and prevent overpayments. We've also taken steps to statewide to require better documentation and reporting practices of hospital overstays by our local departments. This summer, we will upgrade how we track medical and dental care and examinations with the implementation of an electronic health passport. With your partnership, we prioritize placing youth with kin because research shows that children are safer, more stable, and less likely to run away from the homes of caregivers from within their family or communities. Moreover, we wrote and implemented new regulations so now kinship caregivers are licensed to receive the same financial support as other resource providers. In regards to how we have built capacity, thanks to the investment made by the General Assembly, we reformed how we pay residential placement providers who serve children with the greatest mental, physical, and behavioral health needs. We stopped negotiating separate contracts with each placement provider and implemented statewide rate structure based on the types of services that are provided. This new rate structure enables us to better meet the needs of youth who require intensive services in more restrictive settings. Hospitals are encouraged to dial 211 press 4 so that we know sooner when a youth stays in a hospital longer than medically necessary. We are happy to report increasingly consistent use of 211 press 4 by our partners. We've also increased communication and oversight of hospitalized DHS youth, including weekly statewide meetings to review individual cases that I personally facilitate, as well as address placement and treatment needs and identify potential placements before discharge. So far, our results, we've seen strategic changes and systemic investments resulting in significant progress in critical areas. Our kinship placement rate increased by 33%, representing an additional 330 children living with family, whether by blood or choice. This means that we've created more family-based placement options just by placing kids with people they may already know and trust while providing the same financial support that all resource parents receive. 11 Maryland jurisdictions have doubled their kinship placements rates, which includes Caroline, Carroll, Cecil, Dorchester, Garrett, Kent, Somerset, Talbot, Washington, Wicomico, and Worcester counties. Baltimore City, which is the jurisdiction with the largest population of youth in out-of-home care, has also increased their kinship care placement by 18%. Since we began using Benti, a family finding software, in an effort to improve our family finding and preservation services in September of 2025, caseworkers have identified over 4,300 potential kin connections for placement, which is an average of 26 placement options per child. And more connections mean more placement options to meet the child's needs. In addition, the percentage of licensed kinship caregivers soared from 25% in December 2024 to 86% as of December 2025. Implementing Part 1 of our placement provider rate structure is already expanding placement options. The Board of Public Works approved new child placement agency contracts, which increased our CPA beds by 92, which is a 4.8% increase from 1,921 beds to 2,013 beds for youth with more complex needs. Where we're going as we enter into 2026, we are committed to the continued growth of our Family Matters strategy, and SSA will continue to grow and learn from patterns and trends we see and connect it to all of our work with our families, as well as understanding common threads that will prevent child abuse and neglect and reduce the need for out-of-home care. This spring, we launch our Family Matters Performance Cabinet to rapidly prototype how performance and data is managed across all of the DHS programs. We are also enhancing our collaboration with the judiciary and legal partners to share our focus on kinship care and address any challenges that legal partners may experience in child welfare practice. We continue to focus our efforts on improving our data integrity efforts and will continue to refine that process. As such, we've relaunched the public data dashboards to increase transparency. In partnership with the Maryland Benefits and the Chesapeake Regional Information System, also known as CRISP, we will now have a new bidirectional data exchange that will feed medical information for youth ages 11 and under and out-of-home care directly into the Child, Juvenile, and Adult Management System, known as CJAMS. Together, we're driving the use of data to inform decision-making and enhancing accountability, as well as building an agency-wide culture of learning to understand what is working and what is not working. Finally, we are reimagining our engagement with emerging adults to ensure their successful transition to adulthood. We believe that all young people experiencing out-of-home care in Maryland deserve to be connected to trusted networks and thrive into adulthood. We've made meaningful progress, but hard work remains. As we look ahead, we are reinforcing our strategic pillars of family preservation and kinship care by investing in people, practice, and policies that deliver on our vision for Maryland, where all children and vulnerable adults are safe, children have permanent homes, and families thrive, because family matters. I now turn it to my colleague Roman, who's our Chief Financial Officer, to speak in response to the DLS analysis.
Thank you. In response to the DLS recommendation to release $100,000 to withhold, to release $100,000 in general funds, as we concur and appreciate the committee's review of that report. On the 2025 expenditures related to rate reform in our JCR and our closing documentation, we corrected that error. The JCR report was resubmitted on February 12th, correcting the numbers and providing correct analysis of that issue. On page 19, we were asked to comment on the medical state plan amendment for residential intervention for children and out-of-home placements. We respectfully do not concur with the recommendation for a fund restriction. After consultation with the Maryland Department of Health, there is no spa in development nor a plan to pursue this type of spa at this time. We are committed to continuing to explore the future options should fiscal conditions and federal policy allow. We would ask you not to impose a budget cut in this important area. On the DLS request for data on the costs associated with hotel stays, let me provide a few different thoughts. We concur in part for providing partial data for 2026 going forward, and respectfully do not concur in the request for 2025 fiscal year data. We started requiring the collection of hotel costs after making the necessary technical adjustments to the CJM system late in the summer. The 2025 actual information is not available at hotel costs, as those were documented by our local departments in a non-standard manner. We note that the hotel cost data is already provided on a monthly basis to DLS, and there are no planned funds for hotel placements going forward. With respect to one-on-one service fiscal data, once again, the 2025 costs were not documented by local departments in a standardized manner, and we anticipate more complete one-on-one service data starting in the fourth quarter of 2026 and going forward. On page 33, we concur with the request to provide data on child fatalities. On page 34, DLS recommends the release, DLS recommendation to release $100,000 in withheld general funds. We concur and thank the committee for their review. We concur with on page 39 and 40, DLS's recommendation on providing monthly out-of-home placement data on our website. I'll now turn it over to Dr. Studstill for the next response.
On page 41, we were asked to comment on the reasons for the increase and efforts that we are taking as a department to reduce the rate of re-entry into foster care for children exiting to reunification. We continue to further analyze this issue internally. However, thus far, there is no direct causation that we can attribute to this reduction. Children re-enter out-of-home care for a range of reasons, such as parental substance use, abandonment, child behaviors, inadequate access to mental health services, child substance use, runaway behaviors, neglect, physical abuse, sex trafficking, and parental death. These issues may not have been present at the time of our last involvement and/or may have been issues with a different caregiver, which was not part of the previous case. To reduce reentry, we utilize trial home visits as an opportunity to assess a parent's ability to safely protect their children. Efforts also include ensuring families are connected with the appropriate community services to meet their ongoing needs and promote family stability. The analysis noted that DHS should discuss the decrease in in-home family preservation services provided in fiscal 2025, which was noted on page 42 of the DLS analysis. Child Protective Services is the primary referral source for family preservation services. When numbers decline in our CPS program, it can naturally result in fewer families being identified for and referred to family preservation. There has been a year-over-year increase in the number of child protection reports being screened out since 2023. These reports did not meet criteria for a response for various reasons, making it less likely for the families involved to be referred to family preservation services. As our overall CPS involvement decreases, the number of cases eligible for ongoing family preservation support may also decrease. We are undertaking an initial assessment of the data to understand if there are any nuances which exist or if there is a need to revise policy and shift practice based on the DLS analysis. In response to the DLS operating recommended actions on page 45, have several thoughts. Number one, we concur with the first budget restriction language for foster care maintenance payments. Number two, we concur with the second budget restriction language for foster care maintenance payments. Number three, we concur with the third request for a report on child welfare service cases based on the Child Welfare League of America caseload standards, but request that a report due date deadline of December 1st, 2026, so that we might receive complete data through September 30th of 2026. CWLA has had a recent leadership transition, so their effort to update guidelines for caseload standards appears to have gone in a different direction. We concur with the fourth request for various data on children and youth in out-of-home placements experiencing stays in hospitals and hotels, but request a report due date of December 1, 2026, as end of September data will not be available and validated until November of 2026. On the fifth request for a report on our corrective audit actions, we concur. We continue to take corrective action on the items identified in the September 2025 report for the 2020 to 2024 review period and will provide regular status updates to the Office of Legislative Audits. We concur with December 31st of 2026. On item number 7, we do not concur with the request for information on the submission of a Medicaid state plan amendment for the reasons that have been previously stated. On item number 8, for various hotel and one-on-one service costs, we concur in part for FY 2026 actual expenditures, FY 2027 and FY 2028 estimates as they become available. We respectfully request a due date of December 15th, 2026 for the submission of the FY 2026 actual expenditures, as the budget closeout process may not be completed until then. We do not concur for FY 2025 actual expenses as discussed earlier and in our written testimony. We concur with the 9th request on updates to our implementation of the Family First Prevention Services Act, and concur as well with the 10th request for a report on child fatality data. Finally, we respectfully do not concur on the 11th recommendation to restrict foster care maintenance payments funds. While we concur with the intent of this language, in practice, this language prevents any additional recouped funds after maximizing federal match from being reinvested to better support families. And with that, we are happy to take any questions from the committee.
Thank you. My first question is around the tracking system for hospital stays. And if I'm reading it right, you said February 13th that you all had 7 youth?
Yes, sir. 6.
6?
Yes, sir.
Okay. I'm reading MHA's testimony, and they speak to 33 at when they said as of January 31st. So can you just speak to, like, how are you coordinating with our stakeholders and dig a little bit deeper into this tracking system that you all have?
Absolutely. And so we meet weekly with our state partners to understand hospital overstays. The number that we provided for number 6 are the young people that are in the care and custody of the department. The numbers that the hospitals may often represent may be numbers for young people that are not in the care of the department, but they are currently in a hospital stay waiting on a parent to better serve their needs, or they are a part of another state agency system. But weekly within our department, we partner with MDH as well as the Department of Juvenile Services, the Maryland State Department of Education, and with MDH, it also includes the Developmental Disabilities Administration, to have better coordination amongst all of the young people that are known to our respective agencies to determine how we might be able to best serve them as state agencies. Does that resolve your question around the difference in numbers?
It does, in reference to the specific agency. Is there any type of central, like what agency would be responsible for some level of central, or if this is information that you all can get back? I do think that you're speaking to some problem. You're saying that multiple agencies may have folks in hospital overstays, but you're not saying how we're looking at it as a collective, like DHS just isn't on its own island or separated from the state, like we're all a collective.
Correct. We're happy to follow up with our colleagues at various state agencies and determine how we might have a bigger picture or a system for that. There are still some young people that won't be known to any of the state agencies, so numbers may differ between what the hospitals has versus what our state agencies have, but happy to work with our colleagues to determine how we might be able to make that happen in a future state.
This is more of a comment, like the hospitals seem to have a better grip of it. They gave 33, they were able to identify by gender, say it's 20 that are young boys, 13 that are young girls. So like, I get that you all are doing it as a collective, as the agency, but it sounds like stakeholders need to be brought into the conversation because they may have better information than we have.
Mr. Chairman, if I may respond, Webster Yee, Chief of Staff for the Department. The 33 number was a joint effort by both the Department of Health, Human Services, and the Hospitals Association. And so we provided the data to the hospitals. That number and the number that we provided approximately 3 weeks before that was a manual pull. In other words, folks were picking up the phone and calling people. The main disconnect here, and again, this is an item of discussion in the House, I believe, the bill number is House Bill 1559, goes to when is a child in a hospital part of a voluntary placement agreement? What stage is that child potentially in the voluntary placement agreement status? And then ultimately, where we come in, there's some type of court action that has ordered or remanded custody of the child to the state of Maryland. And so our principal focuses on currently the 6. In the testimony, we noted 7, and we've since had 1 child leave and be placed. I think we've had 2 additional kids come up.
Okay. This is, the next question is more of a question from advocates, just making sure that you all can either provide a response or provide a written response afterwards. But the question was, how many private licensed treatment foster care homes does DHS have in comparison to treatment foster care beds contracted with providers?
Instead of rummaging through my notebook, if we could take that and follow back up with the committee in a written response, I don't want to misspeak, but we'll definitely get that information to the committee.
I appreciate that. Senator Zucker.
Thank you very much. I know that the agency is going to be going through a transition, it sounds like. So this might be for the Deputy Secretary. What do you think, like what keeps you up at night at this point? Like what do you think? What is the biggest challenge right now that you think the agency faces?
There are multiple things that keep me up at night. As a local director, I can tell you that knowing that my children were safe, in safe placements, and thriving is something that constantly woke me during the night. Obviously, we want to continue the work that we've already done to ensure that our children are placed in safe but the least restrictive environments. And we want to get, these audit findings under control because the reason why we have audit findings is because there are issues that we need to address and opportunities to improve practice and policy. And so, I haven't been in this seat very long, but obviously I want to continue to focus on making the improvements that improve outcomes for our youth.
Senator Augustine.
Thank you, Mr. Chair. Thank you for the presentation. Just really big picture, there have been so many, right, unresolved matters over the course of years. Can you all share, like, when they will be cleared, particularly those that have been open for multiple years? and/or the plan? Or is the plan a part of the budget submission and everything else? To clear those that have been open for multiple years?
Senator Augustine, if I may, and this is going to be a continuing item of discussion with the committee over the next couple of meetings. To be very clear, some of these repeat audit findings have languished because DHS decided back years ago that they did not want to address the systemic root causes. This leadership team has, in the past 3 years, decided to focus on identifying the root causes and fixing them. That is not a complex magic wand type situation where we can snap a finger and there will be a fix. These issues will only be resolved by maintaining focus over time, not just with the General Assembly, but with all of our partners. We are endeavoring to get as many of the quick fixes this year as we can. You've heard already from my colleagues that we've implemented a lot of the technology and fiscal side issues. Tomorrow, when we're before this committee again to discuss those technology issues, happy to go through that in more detail. We have, I think, over 100 projects on the tech side to work on the technology side. We're also focused on the most important part, which is investing in our people. We have to hire people, we have to train people, we have to make sure that they're supported. And then everything from there flows into what are the policy changes that we can do and what are the operational fixes that we can make. And we are trying to work on all of those. And the goal is to eliminate as many, if not all, of the repeat findings as possible across all of our agencies.
Yeah, so I would add one other thing, which is a part of sort of my writ when I took this job, which was I knew I was going to have to be working. A lot of the audit findings also deal with the local jurisdictions, and that's something that Gloria and I share is a perception of what it's like to work both in the field and at headquarters, and how you have to make that trade-off. But that's one of the things that we've noted a number of times was just being transparent, creating tools. Creating we're working on a fiscal handbook right now for all of the local offices, so they have some standardization in their process, updating document that had not been updated for years. And the only reason I bring that up is just to say that kind of consistency is where we say, well, here are clear rules and guidelines, then accountability can flow from that. And I think that's something that all of us understand sort of as part of how we deal with our professional work. So that is something you're going to be seeing from us. In addition, there are opportunities that we have to keep pursuing in terms of answering questions. So for example, if we put out a new policy and I get 32 separate different questions on how do I implement this, I need to be able to communicate both over time, space, and to people who don't read the guidance, to people who won't listen when I offer the monthly phone calls. All of those things go into that repetition. So we got to meet these local offices where they are and make them feel supported. And that's something that's going to be part of actually resolving not just one finding, but a whole slew of practices and other things that are going to benefit and have all kinds of positive benefits as we begin to unwind that.
Can I follow up on that just a little bit? So if I'm hearing what you're saying, you have your part, but then you're also saying that a significant part of it are the locals who are part of what you are obviously being held responsible for as well. Do we know like which ones are, how they are performing as it relates to the whole, which is of course, do we know that?
Yes, Senator. We have our Office of the Inspector General, which performs a continuing loop, if you will, of audits of the local departments. And so I think they're on a 4 to 5 year cycle, depending on the previous findings. And the Inspector General will go through, they'll document reports. And then what we've implemented over the past year is each time we get that internal Inspector General report on, say, Prince George's County or whatever, we immediately follow up with basically a corrective action meeting of not only everyone agrees with the locals to sit down and go through the findings, but it's also how do we collaborate to fix things? What are the items that are system? What are the items that are local? How do we support folks? One of the biggest issues, and again, we'll talk more about this tomorrow, is Wi-Fi at all of our offices. It's taken us 2 years as a result to procure, budget, and roll out Wi-Fi. And just that one item alone, getting Wi-Fi in all of our offices, is able to then resolve a number of internal findings.
Okay, just one more, Mr. Chair. So, but why, you all help me to better understand how an IG would be the method with which you would be managing the business. I don't understand that.
Yeah, I would like to jump ahead if that's okay, and I'll let my colleagues speak, but just to say, that is one of the methodologies that we use to do kind of accountability, accounting, practice, but I do want to flag two things.
But you would agree that it's your job to hold the folks accountable.
Absolutely.
And the IG has its own independent sort of separate framework. I mean, it's your job, actually, to hold those folks responsible.
Absolutely.
And Senator, we're not disagreeing with that. We actually have an assistant secretary that was brought on whose daily job is taking a look at each of the prior audit findings and working with each of our locals to say, how do we work together to get through that? So I did not mean to imply that we were giving the Inspector General saying, hey, it's your job. No, it's a joint effort. We at the leadership level take it as a joint responsibility between this leadership team and the leadership of each of our local offices.
Okay.
I do have to pipe back in and just say one more thing. Gloria personally leads a monthly call with all of our local leadership. And I'll just say that she's going to bring that perspective to this role in her acting time. And I think all of us know what a valuable contribution that's going to be.
Mr. Chair, he knows how my fondness for, for Ms. Brown. I mean, she's just been a tremendous asset for Prince George's. I'm grateful.
I didn't know that. That's great.
Well, she has been, and she's real capable. But I really am asking you all, like, from a functional standpoint, how are you running this?
If I could, from a social services administration perspective, since that's the topic of this hearing today, when I assumed the role, there was no internal structure, and what I've learned is we've had to restructure the team. I've had to make some personnel decisions and have made several key leadership decisions and have replaced individuals so that we can be better positioned. Now that during the audit, we also were responding to the auditors. I believe in our hearing last week, they also, both OPEGA and the auditors did say that we were more responsive this round. And so we were trying to be as transparent, as partnering as we could. Now that the audit has ended internal to SSA, we have our own audit resolution team that meets bi-weekly. There is a department-wide audit resolution committee, and so our team rolls up to the broader department team. And some of these are, in fact, repeat findings. But one of the things that I learned on how something can be deemed a repeat finding is I can implement said policy to address an issue, but if Roman comes to audit me 6 months from now and someone has violated that policy, even though the new policy has impacted 98% of the people, if someone does something wrong, doesn't follow it, and there is a hit, it will still become a repeat finding, even though we've implemented all the tech issues, we've implemented all the policy, done all the trainings. So there's just a level of constantly having to keep this in front of people. And so my deputy executive director that's here over child welfare practice, in a couple months, we'll be launching an annual refresher training. So every child welfare professional in the state of Maryland every year will be required to do this series of annual refreshers to make sure we're keeping policy and practice in front of people. So those are some of the practical things that we're implementing within our administration to address some of these systemic factors.
Thank you. Thank you for the indulgence, Mr. Chair.
You have any questions, Mr. Chair? Seeing no further questions from the committee, we will have a number of folks that's testifying, so.
Thank you.
Yes, sir. Colleagues, at this time, we're going to go with public testimony. And if we can bring them up in fives, can we bring up Ms. Kendra McAbee, Ms. Haregrove, Carrie Elliott, Byron Mason, and there's another Byron for chair. And whoever wants to go first.
Good afternoon, Chair McRae and members of the committee. My name is Sarah Haregrove, and I'm the Assistant Director of Policy at the Community Behavioral Health Association of Maryland. CBH is a leading voice for community-based behavioral health providers serving vulnerable Marylanders. Within the child welfare continuum, our members deliver treatment foster care, independent living programs, residential group homes, and residential treatment centers. In 2025, Mental Health America ranked Maryland 49th, behind nearly every other state in youth prevalence of major depressive episodes, 47th in youth prevalence of serious thoughts of suicide, 31st in youth with a substance use disorder. Our overall youth ranking was 40th in the country. DC was first. I'm here today to seek your support for the critical full funding of rate reform for child placement agencies, which includes treatment, foster care, and independent living programs. Maryland paid a nationally recognized firm, PCG, to spend the last few years developing a new rate structure model in partnership with DHS and providers. PCG reviewed provider expenses and projected the cost to create a model that better meets the needs of children in foster care. After all of this time, work, and money, provider rates were once again leveled this year. Board rates for foster homes in Maryland have stagnated for years. Maryland is far out of alignment with other states, and it's showing in our rankings. More than ever, the deficits in our child welfare system have been brought to the forefront in recent months, with children languishing in hospitals and other unlicensed settings that are entirely inappropriate and detrimental for our youth. Investing Maryland's limited resources in strengthening child welfare rate reform means that tax dollars are being spent on settings that improve children's well-being rather than harm it. We respectfully urge you to fully fund rate reform for child placement agencies. Investing in child welfare and behavioral health workforce capacity is not just a fiscal decision, it is a moral imperative to ensure that Maryland's most vulnerable children receive the care and support they deserve. Thank you.
Good afternoon, Chair McCray and members of the committee. My name is Carrie Elliott. I work as a family support worker in child welfare services out of the Somerset County Department of Social Services. I'm here today testifying as a proud member of ASME Local 112. I'm incredibly proud and passionate about the work I do for families. My coworkers and I work to preserve families, develop positive relationships within families, and connect families with vital support services to promote their health and well-being. While I love what I do, my coworkers and I experience challenges in our jobs that impact our work. First, our caseloads have a variety of issues we must address. We perform work in and outside of the home with families. Sometimes clients are unresponsive to our efforts to work with them. This means despite our best efforts of contacting them at home by visits or by phone, we cannot reach them. Additionally, at times we are dealing with challenging behaviors with clients, and we must work to escalate behaviors. Oftentimes, we also lack supporting services for our clients close by in our communities. For example, I have cases of out-of-home foster care youth that I must travel across the region and even across state lines to see, such as Baltimore County and St. Mary's County. I also have a youth on my caseload that is now residing in Delaware with a family member, but I continue to monitor their progress and status and travel in person to see them. These challenges are compounded by staff leaving our offices for other jobs. We frequently lose folks to other local government jobs or private sector jobs. We experience challenges with retaining newly hired staff because of our pay is not competitive. We must invest in our state employees to increase our compassion and make salaries competitive. We love what we do and we care deeply for our clients, but we have to make ends meet and make this a sustainable career for public employees. Please support our wage increases in the state budget. Thank you.
Good afternoon. My name is Byron Mason. I'm a proud member of ASME Local 112. I work as a Child Protective Service social worker in Baltimore County. Every day, my coworkers and I respond to allegations of abuse and neglect. We enter homes where children may be unsafe, we coordinate emergency placement, and we work with families who are at some of the most difficult times of their lives. But right now, our ability to serve our community is being threatened by a serious staffing crisis. Vacancies are high, caseloads are heavy, and workers are stretched far beyond what is healthy or sustainable. When there is not enough workers, families wait longer for help, investigations take longer, children remain in unsafe conditions. The financial reality for workers is a major part of the crisis. Maryland families rely on us, but we are struggling to support our own families on our current wages. Like many of my coworkers, I've had to seek secondary employment just to make ends meet. Rising housing expenses, utility bills, food prices, medical bills make it nearly impossible to rely on one state income alone. When employees are forced to work a second job, it becomes harder to rest, it becomes harder to recover, and it becomes harder to give our children 100%. Low pay and burnout make it extremely difficult to keep qualified staff. New workers often leave realizing the pay doesn't match the weight of the work. Experienced workers leave because the workload becomes overwhelming. Every time someone leaves, their case gets divided, and the remaining staff carry on even heavy burden. This cycle hurts the workers, the department, and most importantly, our families. The community pays the price. When we don't have the staff, the community pays the price when we do not have the staff or stability needed to do this work well. I ask for your support in strengthening the workforce and protecting Maryland children. Fair and competitive wage is not just about helping Maryland's, not just about helping workers, it's about ensuring that we can recruit and keep enough trained professionals to respond quickly, make good decisions, and keep children safe. Thank you for your time, and thank you for listening.
Good afternoon, and thank you for this opportunity to speak in front of this committee. I'm Brian Fracke, the Executive Director of Nexus Woodburn, an organization which has been working with some of the most vulnerable youth in Maryland since 1789. Currently, we have a group home for female or female-identifying children that have been or are at imminent risk of being victims of commercial sexual trafficking. Often coming right from a sexual trafficking situation, these youth need an immediate place of safety, specialized clinical services, and an immense amount of structured support in order to begin to rebuild a sense of well-being. We also work with youth and families in treatment foster care. These are the children who have experienced the most trauma, who have experiences so severe that they cannot be in the state foster care system, but instead need trained families that specialize in working with our children who have been through these horrific experiences. Both of these programs have had their rates frozen last year, and in this budget are projected to have their rates frozen again. What has not been frozen are our costs. Utilities have skyrocketed, wages must go up, inflation continues to rise, and the cost of all goods and services have increased. Additionally, due to federal and state cuts, supports and services we used to rely upon have either disappeared or are no longer available at the same cost. These rate freezes are therefore not freezes, but cuts. Cuts to the services we can provide to these children, cuts to the wages we can use to attract skilled staff, and cuts to the future that we can help them to begin to dare to hope. When we cannot provide the youth these services they need, their problems will become more acute. The treatments they require increases, and the consequences become more dire. Not only do they pay at times with their lives, but so does all of Maryland. I urge you to restore the increases for the RCCs or group homes, as well as the rate reform to fully fund that for treatment foster care so that we can provide these children, victims of sexual trafficking and trauma, a future they deserve. Thank you.
Seeing no questions, if we can bring up, and I'm going to call once again Ms. Kendra Maccabee, Robert Basler, Ms. Hessler. And Jane Cronky.
Good afternoon. Good afternoon, Mr. Chairman, members of the committee. Thank you for allowing me to speak. My name is Robert Bassler. I'm Associate Vice President, Arrow Child and Family Ministries. We are a nonprofit that serves over 500 at-risk and vulnerable youth in the state of Maryland every year. Our services include a qualified residential treatment program for young women in foster care and a treatment foster care program. I'm here to kind of give you a real sense of sort of what the impact of the rate reform process that's being discussed has done. The rate changes and the rate setting process changes for residential child care programs allowed us to invest in upgrading facilities, in increasing pay for staff, especially for direct care staff, our lowest paid staff, and directly allowed us to accept more young women into our program, including women who before they were with us were in hotels or in hospitals. The proposed changes to treatment foster care rate reform will do a few things. First, it will increase the board rate that all foster parents get. Many people have referenced the cost of living. We're asking families to take youth into their homes. It makes sense for us to give them enough funds to be able to adequately care for those kids. It will standardize the difficulty of care payment that treatment foster parents get, which right now is individually negotiated by provider. It would standardize it and use a clinical tool to base it on what children's needs are, and would allow us to increase rates for social work staff, which are amongst the lowest in the state. All these things would allow us to increase the number of foster homes in the state and allow us to place more kids in family settings, including kids who have significant needs. Thank you for your time.
Good afternoon, Chair and members of the committee. For the record, my name is Teresa Hessler, and I am here today on behalf of the Maryland Association of Resources for Families and Youth, also known as MARFI. We are representing providers from across the state that deliver foster care, treatment foster care, group homes, independent living services to youth with significant behavioral health, medical, and trauma-related needs. We appreciate the state's continued investment in Maryland's child welfare system. However, the proposed fiscal year 27 budget maintains flat funding for provider rates, and our members see flat funding as a cut. Provider rates continue to rise, including workforce costs, as you have heard, by wage increases, inflation, staffing requirements necessary to operate safe 24-hour programs. Without these rate adjustments, providers are forced to absorb these increases, which directly impacts staffing levels, placement capacity, and ultimately the ability to serve youth. You have heard and will continue to hear directly from providers today and in the future about the real impacts this funding freeze has already had on their services. These are not hypothetical. Programs are making difficult decisions about staffing, admissions, and sustainability. Maryland has been working toward rate reform for many years, and providers have continued to meet evolving federal and state requirements despite outdated reimbursement structures. This budget represents an opportunity to stabilize and increase the system while that work continues. On behalf of MARFI, we respectfully ask the committee to support rate increases and allow the Interagency Rates Committee to function as intended. Thank you so much.
Good afternoon, Senator McCray, members of the subcommittee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association, just to provide information and really to ask for your help. We have a crisis in our state. As DHS referenced, to the best of our knowledge, based on the data Department of Health, DHS, and our hospitals have provided, there are approximately 33 youth that are experiencing a hospital overstay across the state. And this is our guess. So as was mentioned, there's not firm data systems that can track these kids. But many of them are known to DHS. And so it's important, we think, to keep counting them. So this means these 33 youth have been medically cleared for discharge, but due to factors outside of their control, they're stuck living in emergency departments and inpatient units. And few places are worse for a youth, especially those that need therapeutic behavioral health treatment and care. These youth crave normalcy. They deserve to be in a place where they can go to school, they can see their friends. But in acute care hospitals don't offer any of this. And as if this wasn't bad enough, there are also sick children who need emergency department care, they need inpatient care, and those beds are occupied by children that don't need to be there. So really, if you think about the impact, it's not just the 33, it's much more. And I received a call yesterday from a hospital. There's a teenage boy in a hospital right now. He has low IQ, his mom can't care for his needs at home. He spent several months at a different hospital. He went home for a bit. The mom wasn't able to care for his needs, and he's back in a different hospital. DHS has been looking for placement, even considering out-of-state placement. And meanwhile, this boy is stuck. He's just in an emergency department. The hospital is providing food and shelter, but that's not their purpose. And we know this is complicated. If it was easy, we would all solve it. And we know there are gaps across the continuum. So that's what we're asking for, investment in capacity in child welfare, behavioral health, and the Department of Disabilities Administration. A lot of these kids, they have a low IQ, developmental disabilities, autism, and there aren't beds to take them and meet their needs. So thank you for your time and support.
Senator Zuck.
Thank you very much, Mr. Chairman. Jane, so do you, I'm sure you heard the agency talk. They said about the 33 beds, part of the discrepancy is that there's youth that are not within their care. Is that, do you agree with what they, I mean, I don't want to put you on the spot like that, but
Sure.
just seems like there's two different numbers and just wanted to kind of get your input.
Correct. Thank you so much for the question. So I guess it's 6 now that are firmly in the care and custody of DHS. But there's an additional, it's 16 to 17 waiting for a voluntary placement agreement process. So once that process is signed, they'll be under the care of DHS, but they won't sign that agreement until a placement is found. So it's kind of a circular process. And a lot of these kids are known to DHS. They're either waiting for the VPA, that voluntary placement agreement, or the DHS is providing services to the family. Not all the kids are known to DHS, but the majority are. Based on the latest data that we received again from the state, because this is hard to track, 17 were pending a voluntary placement agreement and 5 were working with DHS, providing different services for their families. So it's a large majority are within the DHS sphere. And we know this isn't all on them. If they could find beds, they would. That's why we're pointing to the capacity problem. These kids are just waiting in the hospital because there's nowhere else to wait. And it's awful for the kids. There was a senator that came to tour to meet with a child at a local hospital, and they said, this is worse than prison. Like, these children are being imprisoned, and it's just not fair to them and the staff that take care of them every day. And if you think about your own kids or your nieces and nephews, like, no one would want this for their kids. So that's why we're here just advocating for some other place, even if it's to wait, where they can go outside, they can play soccer. You can't do any of that in the hospital.
You heard the agency speak to some of the coordination that's going on with interagency, and then they said that they were touching base with stakeholders. How often do you all jump on calls in reference to the coordination of these hospital overstays?
Great question. So I will give a lot of credit to DHS. MHA, we meet with them monthly with the team. I know Dr. Stutstill and several members of his team. And the hospital liaison, they have a different name that's broader. Jenny Jumblick, before, she would meet weekly with hospitals, daily sometimes. And the new liaison, Ms. Lolita, is doing the same. The problem is they have these meetings and there's no progress. I kind of talk about different placements and the kids just wait. So for example, that number of 7, we've been getting that same number of 6 or 7 for months. So these kids, maybe a few go in and out, but they tend to stay. And so they're having conversations, but there's no movement because there's no place to go. So we appreciate the communication, but until you have places to go, we're just going to keep being in the same cycle.
Thank you. Seeing no further questions, I think that it's important to let each and every advocate know that we all play a role, and you definitely play a role, and thank you for helping us be better as a state and delivering a better level of service. To Ms. Brown-Burnett, like I said, all my Prince Georgians have spoken so highly of it. It ain't just Augustine, it ain't just Senator Augustine, it's a whole gang of them. And they have a significant amount of confidence, but more importantly, they're just proud of the service that you've given, but how you've elevated to this level. And I feel very confident. I know there's some level of nervousness, but there are a lot of my peers that I respect that have confidence in your level of service that you're giving to the state of Maryland and the entire agency. Ms. Bugel, thank you as always in reference to just helping us see the board a little bit more clear. I think that we can see the strengths, but we also see a number of the challenges that await us, and that would not be done without you. Colleagues, seeing that there's no more agencies at this moment, this further adjourns until tomorrow.